Good evening, everyone. How are you all? Okay, so welcome to First Aid MC MCQ 2 weeks free session. So you guys most of you know about me. So I am Dr. Arshan. So we are actually taking the 2 weeks free session in terms of First Aid MC MCQ. And we're going to have the new 5 months MCQ course. Now you are already doing the course in a view that this is a part of the course as well. So you get to know us, you get to see that how we take classes and what the course includes. If any time you still have any difficulty understanding how we actually take the course and anything that you want to know, feel free to ask us during the class time, especially at the end of this class. I would be happy to answer any queries. So tonight class is on cardiology question solvation. So did you guys go through the theory class that we have taken in the last 2 classes? I know that it's very hard to finish in this very short time, but still if you start it, you will understand today's topic a lot much better way. Good. So some of you did. That's really nice. Now in case of cardiology question solve, we will mainly focus on the theory class that we have taken and try to solve some questions. Now, one of the things, like those of you who are in the Facebook, I can see like 4 of you are in the Facebook. If you can come in the Zoom session, that would be easier for me. And you might get a little difficulty with hearing today because of the flood warning in here. They cut off the internet, the NBN connection that we usually have. It's a 5G network, but for the last 2 days, we are not getting any connection. So just because of today's class, I can't cancel it. I'm taking the class, but it's a phone with the phone network. So sometimes you might get a little bit of trouble with the network. I hope not, but still if you get, just let me know. So if you are having trouble in the Facebook mainly, come in the Zoom session. Zoom session will be fine, I guess. So let's start our tonight session. So how question solve class works? Remember, there are 2 kind of question solve class you will get in the course. One is, this is one of the kind where we do the theory first, and just based on the theory, we do a subjective question solve. That means subject wise. If we are doing a cardiology, we will do question solvation on cardiology. But there are also random question solvation class, which is coming up on Thursday. So on 17th, you will get one like that. So join that, you will get to know the random question solvation as well. Okay. Now, this is a 17-year-old male running a race and suddenly collapsed on the floor. Luckily, someone was there, performed CPR as the patient did not have a palpable pulse and resuscitated him. Upon arrival to the ED, it is revealed that his father died at the age of 28. He is now alert, asymptomatic, ECG non-eventful. What would you do next? So someone who is young like that, having a sudden collapse and family history of sudden cardiac death, there are 2 possibilities. One, it's HOCM, so HOCM. Another, what else can it be, guys? So sudden cardiac death, sudden collapse, what else can it be apart from HOCM? There is a condition which also comes just similar like that. This is called congenital QT prolonged syndrome. So congenital QT prolonged syndrome that also has a similar feature. So sudden collapse and having a family history of sudden cardiac death. So that's why doing a ECG is very important. And if ECG normal, it can you can rule out prolonged QT syndrome immediately. Now, it's most likely a HOCM patient. Okay, so what you want to do, send him home, arrange an outpatient consult with a cardio, send him home, admit and refer for cardiologist, team consult, outpatient echo, stress echo. For someone like this, we would like to admit the patient because outpatient echo can take a lot of time to have done. So we will not wait for that because patient already got a collapse and patient had all the features related with HOCM. We will go for admission and cardiologist team consult. And in the hospital, we can do all the echocardiogram that he needs. Okay, so that's your answer. Next question, a young athlete presents with history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient father had a sudden death at very young age. What is your initial treatment? So again, it's HOCM, right? So same kind of question, but they're asking for initial treatment. So what is the treatment for HOCM? Remember what kind of heart failure HOCM causes? Diastolic heart failure. So for diastolic heart failure patient, what we give? Beta blocker or calcium channel blocker, which is rate limiting calcium channel blocker. So which one is here? Verapamil, right? So verapamil is your answer in here. So you guys remembered a lot of information, I can see. Very good. So we already discussed that. This is a chart from your Kaplan step to CK, and you can find out that which one is contraindicated in a patient with HOCM. Now, look at here that a young girl, 15-year-old, collapsed at exercise. Her father had a HOCM. So you already got it from the stem. After ECG and echo, you found no abnormality. What is your next step? Holter monitoring, stress echo, repeat echo now, repeat echo after 3 years. Remember, I told this one in the class that if you suspect someone to have a HOCM, especially if she had a collapse and father history positive, you would definitively go further. Even though it's the normal echo, we would need to do a stress echo. Okay. There is no screening period like that, but because sometimes it can be familial. So we advise these patients to have their first degree relative to have a screening for HOCM. Still, we don't do any genetic test for HOCM. This is available, but we normally don't do it unless it is really needed. But normally just a ECG and the echocardiogram as a screening we do. But there is no specific time period for that. Anyone at any age group can have it. Next, a 9-year-old male was running, playing football, and suddenly collapsed on the floor. Upon arrival to the ED, he is revealed that his father died at the age of 28. He is now alert, asymptomatic. What would you do next? So I have shown you 5 questions from similar topic, and this is how exam works. They just change the question, but as long as you know the theory, you will understand what they're asking. So what will you do next? Tricky thing if you don't remember what I told. Yes. Do you want to do Holter, stress echo, repeat echo, ECG, or echo now? Now, always if they say next means initial. So what is your initial test for a patient like that? ECG, right? Even in the previous question, you found that they have done ECG first. Sometimes see that they have done ECG and you can find left ventricular hypertrophy. So always we'll do a ECG first in this kind of patient. So ECG will be your next test in here. Okay, so that's all done with the HOCM questions. Next, murmur. 16-year-old male who presents with ejection systolic murmur. So this will be ejection systolic in second left intercostal space. Which of the following is likely to be the diagnosis? Try to remember which causes ejection systolic murmur in the second left intercostal space. Now, I understand that if you get it wrong, that's fine because we haven't discussed ASD, VSD with you. Now, I know that most of you will choose A in here, but remember one thing, aortic stenosis. Try to remember the picture of the different places of murmur. Aortic stenosis murmur, where we get it? Aortic stenosis murmur is in the right second intercostal space, right? But you have got it in the second left intercostal space. So that doesn't go with aortic stenosis murmur. So see that it's a little tiny detail which you need to be very, very careful. If you are not careful, you will end up getting it wrong. Whenever it comes in the second left intercostal space, think something in terms of pulmonary. So pulmonary valve stenosis, pulmonary regurgitation, pulmonary hypertension, something in the pulmonary will always cause problem in the second intercostal space in the left side. Not only just that, this second left intercostal space ejection systolic murmur is basically caused by the ASD. So atrial septal defect, I'll go through that a little bit. So VSD and ASD. First, start with ASD. So atrial septal defect means that you guys remember the simple picture of heart. So this is your right atrium and that's your left atrium, right? In between right and left atrium, you have septum, which divides these two atrium. If someone have a defect in this septum, that's what we call as ASD or atrial septal defect. Now, the symptoms, some patient can get it during childhood if it is a really bigger ASD. For a smaller defect, usually you will get it in more older children, like even 16-year-old can have a ASD feature. If you look at here, with hemodynamically significant lesion, you can get two kinds of murmur in ASD. You can get a diastolic rumble, that's a diastolic murmur, and normal ASD patient will also get a ejection systolic murmur along the left mid to upper sternal border. So they usually get it in the upper sternal border in the left side. So our patient is actually getting this ejection systolic murmur in the left second intercostal space. The murmur is coming from here. Now, if you remember the pathophysiology a little bit, if someone has atrial septal defect, what they have. So let's think what happens in here, that there will be a gap in between right and left atrium. So blood will flow from left atrium to right atrium, because always the blood flow or pressure of blood is higher in the left side of your heart. So initially, blood will flow from left atrium to right atrium. So more blood pressure will be in the right side gradually. Then more blood will come through the tricuspid valve to the right ventricle. From right ventricle, blood will go to the pulmonary artery. So there will be more blood going into the pulmonary artery. So eventually, this patient will develop high blood pressure in the pulmonary artery. And that is what we call as pulmonary hypertension. So this is actually a complication of ASD. So that's why our answer in this question will be ASD with pulmonary hypertension. That only goes with the murmur position and type. Okay, is this clear for everyone? And if you remember, aortic stenosis murmur is ejection systolic murmur in the right second intercostal space, right? Mitral stenosis murmur mid-diastolic murmur in the apex. That means left fifth intercostal space. Aortic regurgitation murmur. What's the murmur of aortic regurgitation, guys? Early diastolic. Very good, Dr. Farhan. So early diastolic murmur in the left fourth intercostal space. So even though if you just come into if you see that only knowing mitral and aortic valvular problem, you can easily get your question done in the exam. Which one to repeat, Dr. Shahid? The pathophysiology, I guess. Yeah, okay. So have a look into this picture. If we draw it again. So that's your heart. Now, in case of atrial septal defect, there will be a connection between two atrium. Blood will come from left atrium to the right atrium, right? So normally the blood is not supposed to go into this pathway, but because of this gap, now blood will come to the right side because this left side has got more pressure. So always if you have a pressure, you can always push it to the other side. So this left heart is always a stronger one. Now, more and more blood will come to the right atrium, then the blood will go to the right ventricle, and from right ventricle, where your blood goes, from pulmonary artery to the lungs. So now more blood is going through the pulmonary artery. So that means there is increased blood pressure in your pulmonary artery. That's what we call as pulmonary hypertension. Okay, clear everyone? Good. Moving into the next question, a young guy, while playing cricket, suddenly had a syncopal attack. Always when you are cracking some question, look at the age of the patient, sex of the patient, and then you go for the presenting complaint. So had a syncopal attack. See that you don't need to even read the whole thing. You just look into the important word that will help you to diagnose the condition. So young guy had a syncopal attack without any convulsive feature. That means it's not epilepsy. See, there is an option of epilepsy. You can easily cross it out. Soon he spontaneously recovered and started fielding and continue playing rest of the game. So he had a sudden syncopal attack and then soon he spontaneously recovered and started playing. That means no confusion or anything. So if someone got a syncopal attack, which happens suddenly and recover also as soon as possible, or you can say rapid recovery, what does it suggest? So what is the cause of your syncope? Is it a vasovagal syncope, cardiac syncope, neurogenic syncope, or postural hypotension? So we haven't discussed syncope a lot, right? So let us discuss it a little bit so that you understand the type of syncope much easier. What is postural hypotension? Postural hypotension means if a patient feels dizzy or lightheadedness when they change position from sitting to a standing position, or sometimes from lying to sitting position. So when they change position, their blood pressure goes down. And that's the time they feel dizzy. Sometimes even that dizziness can become a syncopal attack. But our patient did not have anything like that. So postural hypotension is gone. What is vasovagal syncope? Vasovagal syncope is very common physiological phenomenon that happens in a normal young adult also. Most of the time, you will find out that patient might be overexerting in a hot, sunny weather, or maybe standing for a long time. Okay, so when patient is overexerting in a hot sunny weather, prolonged standing, sometimes that can stimulate vagal nerve. And when vagal nerve gets stimulated, what happens? It causes peripheral vasodilation. Peripheral vasodilation means in the extremity, now there is more accumulation or pooling of blood. So if there is more blood in your extremities, so your heart is not getting blood supply properly. And if heart is not getting blood supply, it's not pumping blood to the brain, and your brain is getting lack of oxygen because of lack of blood supply. And that's the time you get a syncopal attack. So that's vasovagal syncope. Our patient did not have anything like that. And vasovagal syncope, important thing is they get a prodromal feature. That means it happens gradually, and recovery also happens gradually. So they know that they are going to fall. So they feel lightheadedness, they feel blurring of vision, sweaty, and then they have a fall, and recovery is not rapid. They recover gradually. Okay. So that's vasovagal syncope. Whereas cardiac syncope, it happens rapidly without any prodromal symptom, and patient also have a rapid recovery, just like this patient. So our patient having a cardiac syncope most likely, even though it's a young guy. Neurogenic syncope, usually you will find out some neurological feature in this patient. So neurogenic also goes suddenly, but comes back in minute. Okay, so now vasovagal seizure, it also falls under kind of neurogenic syncope sometimes. Okay. Now, most of the time, neurogenic syncope means maybe patient might have some other brain-related problem, like maybe a increased intracranial pressure. Patient might have, you can say, any brain infection, brain tumor. All of the brain-related causes can give a neurogenic syncope also. Okay. And you can go through this link, which is the AFP guideline, very good guideline for syncopal attack. Clear, guys, about the syncope? Now, if you get a patient with a syncopal attack, what will you do next? Like our patient, that young guy who had the syncopal attack, and you are suspecting it's a cardiac syncope. What is your next test? ECG. Very good, guys. So you guys are understanding what AMC asks. Now, let's say in the ECG, everything is normal. Will you stop there, or will you do something else? Not echo. Echo will not help with a, like echo can be, but what will be the best approach? For a young guy, I would not think about too much about cardiac enzyme, right? For a 15-year, 16-year, troponin has nothing to do, not also carotid artery Doppler. Holter monitoring would be a best approach. Okay, for someone having a cardiac syncope, after ECG, Holter monitor would be the best approach. Okay, and then with the Holter, you would have to also do a echocardiogram as well. But if in between Holter and echo you have to choose, you should choose the echo first, Holter first. Because why? Holter can suggest that maybe the time when you did the ECG, that time patient did not have any arrhythmia or no other rhythm related problem. But if you do a Holter monitor, it will check your heart rhythm in 24-hour time. And it can show that if this patient having any latent arrhythmia, which you are not able to get by this time. So always in these cases, first ECG, if not positive, then you go for Holter monitor. And after Holter, you can do an echocardiogram just to rule out some other causes of syncopal attack. Okay, good. Next, chest pain. A 45-year-old male presenting to the ED with left-sided chest pain radiating to the left arm and jaw. So now you are worried about this patient. There is no ECG changes and troponin is negative 4 hours since the onset of chest pain. He has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? So obviously you will think that this patient might have MI, but ECG normal, troponin normal. Still, we can't totally rule out MI, but at the moment, what do you want to give? This patient having chest pain. Nitrate? Sorry. Can we give nitrate to this patient? No. Why? This patient is on sildenafil. Okay, it's contraindicated to give nitrate in a patient who is on sildenafil. So cross that out. How about heparin? Are you going to give heparin at this moment? No, because heparin is only needed if this patient is diagnosed with MI, either ST elevated or non-ST elevated. We still haven't got any raised troponin, no ECG changes. So at the moment, no need of heparin. How about paracetamol? In this chest pain, paracetamol has nothing to do. Beta blocker, not now. Maybe in the next time, or maybe when you are going to discharge this patient, but not at the moment. So the best approach is giving the morphine for this patient because of this chest pain. Okay. Now, let's say they are asking you what is the next most appropriate management. Management means both investigation and treatment. Always remember that. So in this case, after giving morphine, what else you want to do? Like there is no ECG change, no troponin after 4 hours. Is there anything else you will do for this patient in terms of investigation? Let's make it easier. Nothing to do with the X-ray. Serial ECG and serial troponin. Very good, Dr. Faiza. So yeah, so that's the thing, because it's just 4 hours. Maybe troponin is still, it's not the time to troponin to get totally high. It takes 4 to 6 hours for the troponin to get peak or to get raised in the blood, okay, after the chest pain. So it's just 4 hours. So we have to do a repeat troponin and a repeat ECG to rule out MI. You can't discharge the patient until the repeat tests are negative. Okay. So very important. Next, another chest pain. 72-year-old patient presenting with severe chest pain radiating to his back. On cardiac exam, you noticed diastolic murmur. Chest X-ray shows widening of the mediastinum, ECG given. What is the most appropriate management for this patient? Now let's have a look to the ECG. We haven't done the ECG yet, but let's just go through it a little bit. In ECG, you have got chest lead and limb lead. From V1 to V6, these are your chest lead, and lead 1 to lead AVF, or you can say lead 1, 2, 3, AVL, AVR, AVF. These are your limb lead. So normally you look for any ST elevation or ST depression or T inversion in a patient with chest pain. So if you look at here, what you can see, this is your isoelectric line. Okay. And you can see this is the P wave, that's your QRS complex, and this is the ST wave. Normally, this ST wave should be here along the isoelectric line, but this patient having ST depression. So V1 ST depression, V2 ST depression, V3 also ST depression, V4, V5, V6 a little bit of elevation, Then look at lead 1 and AVL. Lead 1 is fine. Lead AVL having ST depression. Now these are anterior lead. Lead 1, lead AVL, V1 to V6. Then you look into the inferior lead. Lead 2, 3, and AVF. These are your inferior lead. If you look at here, you can see this is your ST elevation. See the ST elevation? Now this patient has got ST elevation in lead 2, 3 AVF. This patient has got inferior MI also. So sometimes patient with aortic dissection can also got complicated with a acute MI. Okay, so this widening of the mediastinum, diastolic murmur, severe chest pain radiating to the back, that's your aortic dissection. The ECG that you have got, that has also acute MI. So this patient needs to be treated for both. So what you have to do, give alteplase. For someone who is having aortic dissection, you can't give thrombolytic. The patient will die on the table. So cross it out. Aspirin, intravenous morphine. No, they're asking the most appropriate management. So you have to choose something definitive. You want to give morphine, beta blocker, and arrange for a transesophageal echo. Refer the patient to cardiology clinic. Consider urgent MRI of cervical and thoracic spine. Nothing to do. Now, before referring this patient, and referring to a cardiology clinic will not do anything at this patient. Okay, so you need to admit the patient, start the patient with morphine, beta blocker, and arrange for a transesophageal echocardiogram immediately. Okay, so that's your most appropriate management. Morphine for the chest pain, beta blocker, we give it in aortic dissection patient, and also transesophageal echocardiogram will definitively show if this patient has got aortic dissection or not. Okay, so that's your widening of the mediastinum you can see in the X-ray. And these are your aortic dissection. One is aortic dissection type A, and this is the type B. We discussed about it in our chest pain class. Okay. Next, elderly man with multiple falls during the day, especially in the morning after waking up. ECG found left ventricular hypertrophy and multiple ventricular ectopics. Orthostatic or postural hypotension was also noted. How will you investigate this patient further? So you want to do a repeat measure of blood pressure in supine and prone position, 24-hour ECG Holter, serum electrolyte, or echocardiogram. Now, this is a tricky one. So someone who is feeling dizzy, especially in the morning, and having fall for that, and you have got orthostatic hypotension, it could be postural hypotension which is causing it. But in the ECG, you have found left ventricular hypertrophy and ectopic. So something in the heart can also cause it. Maybe something more than just a ectopic. You don't know it. Now, echo will not do anything. As I said, that if someone having fall or syncopal attack, you have to do a Holter monitor first. Now, can we do this repeat measurement of BP in supine and prone position? No, it doesn't do anything, because to find out if there was an option in here that a repeat measure of BP in a standing and sitting position, that would be the best option. Because if you just get one-time orthostatic hypotension, it does not confirm it. So you have to do a couple of repeat blood pressure measurement in sitting and standing position. If that was in the option, that would be your next step. Now, this one is just a trap. Some people will choose it without even reading this one. Okay, so not this one. Serum electrolyte has nothing to do at the moment. Echocardiogram and Holter. Always remember, if you get a patient with fall syncopal attack, you have to do a Holter monitor, because in this patient you have got multiple ventricular ectopic. That's a arrhythmia. Someone who has something like a ectopic, they can have underlying other feature, like even a heart block or maybe a ventricular tachycardia sometime. So that's why we have to do a Holter monitor in this patient. Okay. Echocardiogram, why we do echo and what echo shows us. Echocardiogram gives you the heart ejection fraction. So especially to rule out heart failure, echo is really good. Sometimes echo can give some regional wall motion abnormalities that can be present in some patient with reversible ischemia. Okay, so for those two things, usually echo is good. Echo does not give you any heart rhythm related problem. Okay, so you can't get any finding about heart rhythm by doing an echocardiogram. But this patient already having some rhythm related disorder, ectopic should not give this multiple fall. Something else is there. You have to find that out. So that was actually management of syncope or multiple fall. If you get sudden, then mostly cardiac or neurologic. Regaining consciousness. If it is sudden regain of consciousness, that's cardiac. If it's gradual, then neurologic. Most likely underlying epilepsy or seizure. So we do head CT scan and the EEG. For cardiac, we do either echo or this Holter. Echocardiogram, if examination suggests the patient having any murmur, then obviously we should do an echocardiogram. Okay. If cardiac exam normal, no murmur, then we should go for Holter or telemetry. Okay. Any questions so far, guys? You guys are understanding? Am I being so quick for you? All right. Next, a young patient has been getting multiple lightheadedness, also feeling dizzy. His clinical features are normal, chest X-ray ECG normal, Holter monitor reveals ventricular ectopics. What you will do next? See that in the question you get answer of your previous question. So always remember, that's also helpful. If you go through a lot of questions, you will get answer to your previous question or other questions. So this same, they did ECG, they did Holter. Anytime you get lightheadedness, dizziness, and you are suspecting it could be cardiac, we do Holter. Holter reveals ventricular ectopics. So you want to reassure exercise tolerance test, dobutamine induced echo, it should be induced, and a plain echo. Now, young patient having ventricular ectopics. Have a look. So this is the palpitation chapter that we haven't done yet, but let's discuss the ventricular ectopic a little bit. So ectopic beats are pretty common. Most of the time, these are asymptomatic. Symptoms are usually noticed at rest in bed at night. Drugs which can cause this are digoxin, Look for evidence of ISD, mitral valve prolapse, thyrotoxicosis, those things. Now, if symptomatic, but otherwise well, with a normal chest X-ray and ECG, reassured the patient. Now you have done ECG, you have done chest X-ray, you have even done a Holter monitor. If that is positive and patient is otherwise well, but still obviously someone having a ectopic beat, they will feel a little bit of dizzy. But if chest X-ray normal, ECG normal, reassure the patient. Nothing else you need to do. Drug therapy. Never commence drug therapy without performing an echocardiogram. And usually antiarrhythmic drug will be given. For troublesome symptom, beta blocker can be used sometimes. Okay. Now for this patient, it's a young patient. Patient is symptomatic, obviously, but everything is normal. Clinical features normal, chest X-ray, ECG, Holter, everything is normal. You just reassure this patient. But if this patient was an elderly patient, you would do an echocardiogram, because for an elderly, having lightheadedness, dizziness, that's needs to be further investigated. Okay, but for a young patient, we don't need to bother too much. Okay, all good so far, guys. So I think like we'll take a little break at the moment, and then we will again do some of the questions. Yeah, even after ventricular ectopic is not so important, especially for younger patient. But for elderly patient, we can, if they're symptomatic, having dizziness, lightheadedness, you should do a echo, even after ventricular ectopic. So in elderly patient having, in this patient, your next investigation, so see that first you will do ECG, you can do a chest X-ray, Holter monitor, and the last will be echocardiogram. After ECG, we would rather go for Holter first, and then we'll do the echo. Okay, so let's take a 10-minute break, and then we will again do some of the questions, which is very important for you. So now it's 9:15 in here. So we'll just come in 9:25. Okay. So just please wait for 10 minutes. Thank you. All right, everyone. So let's start again. Okay, so this is one of the drug side effect question. Now it comes with a longer explanation. It's not like just 2-line question. It comes with a lot of information in the exam. Now, as a gist, you can see patient on amlodipine, amiodarone, furosemide, aspirin, and having intermittent fall. You have found that it looks like hyperkalemia. What do you think that the cause of this hyperkalemia? So is it amlodipine, furosemide, amlodipine, amiodarone, aspirin, amlodipine, aspirin, furosemide? Now, it's a little confusing and one of the most controversial question. If you look here, always when you get a drug-drug interaction, you have to find out each and every drug, what is the side effect can it be? Now, furosemide causes hypokalemia. Amlodipine, it can cause hyperkalemia in some way, but hypo and hyper should counteract each other and it should not be the cause of hyperkalemia. Amlodipine can increase potassium as well as amiodarone can cause it, but not too much explanation about how they do it. But there is very slight risk of hyperkalemia with these two medications. Aspirin and amlodipine, not too much. Aspirin doesn't cause too much hyperkalemia. Same with this aspirin furosemide. Furosemide causes hypo, and aspirin has nothing to do with potassium. So this usually has nothing to do with hyperkalemia. Most likely this one could be your answer. But again, it's one of the controversial one. Don't waste too much time on controversial things. That's the way it is for your preparation. You will get to understand that a lot when you go into the question solvation and everything. Next question, ECG of an adult presented with chest pain, cardiac enzymes and first ECG is normal, blood pressure 120/70. After 8 hours of observation, his BP goes down to 89/50. ECG showing supraventricular tachycardia with heart rate 150. Now, we haven't discussed these things in your theory class, but just because we will not have any ECG-based discussion, like no ECG-based question solvation. So any ECG-based question, we are just discussing it here as well. So just for that, let's just discuss it along the way. Now, if ECG shows supraventricular tachycardia, and heart rate is obviously 150, so it's more than normal. The important thing, supraventricular tachycardia management can be done by just some conservative approach, non-medical approach, like you can try with some Valsalva maneuver, carotid massage. You can even immersion of the face in a cold water can stimulate the vagus nerve. So those are the initial measurement that you do, but you have to look for the hemodynamic stability of a patient before you go for anything. If a patient is unstable with a SVT, that patient needs to go for immediate DC or synchronized cardioversion. Now, why I'm saying that this patient is unstable? Blood pressure was 120/70. Now it's 89/50. So that's a hypotension. Patient is going into shock. So this patient will need a synchronized cardioversion. Okay. So any hemodynamic instability, anytime if you see what are the features of hemodynamic instability, patient will be diagnosed as hemodynamically unstable if patient blood pressure is below 90/60, if patient having altered mental status or confusion, if patient having severe chest pain along with the SVT, those suggest patient is hemodynamically unstable. Mostly if it's hypotension and also the confusion, these are the most two important criteria where we have to go for synchronized cardioversion. Okay. If patient was hemodynamically stable, even after carotid sinus massage, vagal nerve stimulation, if the heart rate was still high, then you have to go for medical treatment, which is adenosine or beta blocker. Okay, so hemodynamically stable patient, first try with vagal nerve stimulation, not working, then medication. First line medication is adenosine. If adenosine is not possible, then you can try for beta blocker, calcium channel blocker. Okay. And if hemodynamically unstable, then you have to go for synchronized cardioversion. Now, what is the difference between DC cardioversion and a defibrillation? When we do defibrillation is mainly for two conditions. If someone has got ventricular tachycardia without any pulse, or if patient having ventricular fibrillation, these two patients will get defibrillation. Okay. The difference between these two, that you don't get any. In case of DC cardioversion or synchronized cardioversion, this is P wave, then QRS complex. When you see R wave in the ECG monitor, you give the shock. So that's what we call as DC or synchronized cardioversion. But in VT without pulse or VF, there is like it's a chaos in the ECG. You can't see where is the R wave coming. So you have to just give it like in regular interval. There is no synchronization with the ECG in here. So that's why that is desynchronized cardioversion or defibrillation. Okay. Next, a patient on digoxin, bisoprolol, thiazide, long-term history of hypertension and congestive heart failure and AF. Stopped taking medication for 3 weeks while on vacation. Now you have to look at what is the condition this patient has got: CCF and AF and hypertension. So that's why he is on digoxin, bisoprolol, and thiazide. Stopped taking medication for 3 weeks while on vacation. Now presents with edema up to his knees and a raised JVP of 4 centimeter, but with clear chest sound. Now this is very important. If you get a patient who has stopped medication, obviously this patient will start to get congestion in the body or fluid accumulation in the body. As you can see, this patient already got edema up to the knees, JVP is raised, but clear chest sound means that it is not pulmonary edema yet. It is important to know in terms of this guideline that if someone has no pulmonary edema, no dyspnea, and chest sound is clear, you don't need to just start the patient with furosemide. Okay, you start all the medication the patient was taking previously. So you recommence every medication again. You can also see blood pressure is high, pulse irregular. What you do as an initial management of this patient. So initial management is to recommence all medication. Okay, now question comes in here that patient is dyspneic. And also you can get some bibasilar crepitation. When you get bibasilar crepitation, patient is dyspneic, you start the patient with furosemide first and then gradually reintroduce all other medication. Okay, so it's very important. Now, this patient already on a thiazide diuretics, on bisoprolol, digoxin, everything patient is taking, that should be fine for edema that he has got. You don't need to start or add a furosemide in here. Okay, no need. A ECG is given showing AM spike. Sorry, Dr. Durain asked that, can you please repeat defibrillator? Defibrillator means you are giving shock to the patient. Now, defibrillator means it's an unsynchronized one. That means you give it in VF patient. VF patient has chaotic heart rate, heart rhythm. So you can't get R wave or anything actually. So it's very chaos. So it's very hard to give it like synchronized, where you just synchronize with the R wave in the ECG. Okay, so you just give one shock. It does not depend on the ECG at all. So we started with this one, right? So ECG showing AM spike, QRS complex in all lead. Also, like you can say, it's AM spike everywhere. AM spike suggests bundle branch block and irregular. That means this patient has got AF. Now, this AM spike, without looking into the ECG, it's very hard to say what it was. Heart rate is 150, so that's high. So it's obviously ongoing AF. Scenario gives patient with hypertension, blood pressure 150/90. Patient is taking only atorvastatin, no chest pain. What will be your management in this patient? So it's basically AF management. For atrial fibrillation, you have to start with, again, if the patient is vitally stable or not. If vitally stable, then you can try some medical management, either with rate control or rhythm control. Usually we start with the rate control medication, which is beta blocker or calcium channel blocker. So metoprolol will be your first choice of action in here. Okay, so that's your management. If metoprolol or calcium channel blocker does not help, you can try some anti-arrhythmic drug like sotalol, amiodarone, flecainide, those medication. That's rhythm controller. If patient is hemodynamically unstable, then the management will be DC cardioversion, just like SVT. Okay. Now let's say I just changed this question where heart rate is 90. What will be your management? In that case, you don't need to give metoprolol or verapamil, okay? Because you don't need to do rate control. His heart rate is fine. There are atrial fibrillation where your heart rate is normal. Okay, so that is called atrial fibrillation with a normal ventricular response. And this one will be called as a atrial fibrillation with a rapid ventricular response. For a rapid ventricular response like this, you have to give beta blocker or calcium channel blocker. But if it was normal, like 90, then you have to think about anticoagulation, because that's the second part of managing a patient with AF. AF patient is high risk to develop a stroke, because when you get AF, there is, let's have a look. In the left atrium, you usually get a lot of turbulence of blood, and it tends to form clot in here. And this clot can get dislodged, and from the left atrium, it goes to the left ventricle, and then it can go to your brain and cause a stroke. It can go to your mesenteric artery, causing a mesenteric ischemia. So for a lot of things can happen. That's why you have to consider about giving anticoagulation. But in case of anticoagulation, we have to also get more information, like about the Chats-Vusk scoring system. If the Chats-Vusk scoring system shows that this patient is high risk, then we will think about giving some anticoagulant. Nowadays, if the patient is not having any valvular problem, we can give them newer oral anticoagulant, which is mainly apixaban, rivaroxaban, dabigatran, those medication. If patient is having valvular pathology with AF and their chest first score is high, then we have to go for warfarin. Okay, so it's a lot of discussion about AF. We are not going into that direction today. When we will discuss AF in the ECG, we will discuss it more. No, we don't need to anticoagulate first before controlling the rate. It's not needed. It was previously in Kaplan, they have written something like that, but it's not needed. You control the rate and rhythm first, then you try to find out the Church-Wasser scoring, and then make sure according to the Church-Wasser score, you have to give either warfarin or any newer oral anticoagulant. Is this somewhat clear, guys? I know it's a lot to take. About AF, there is a lot to discuss. We'll discuss that in the ECG class. A middle-aged man, known hypertensive, started feeling dizziness, and he feels his heart is racing. It occurred after running today. There was also a travel history few days ago. Very important. He is on irbesartan, let's say ARB, and thiazides, well-controlled hypertension, no mention of diabetes, BP is okay, no postural change. What is the most appropriate next investigation? What is your diagnosis for a patient who is hypertensive, feeling dizzy, having palpitation, having a travel history recently, pulmonary embolism? Any patient having pulmonary embolism, if you get a patient, just a recent travel history with a long flight, now having feeling of dizziness, palpitation, shortness of breath, chest pain, you immediately think about pulmonary embolism. For that patient, you don't think anything else. You don't do D-dimer, you don't do anything, you do CTPA immediately. Okay, we'll discuss pulmonary embolism in detail in our respiratory class. Another controversial question. So 60-year-old male, 10 years history of hypertension, feeling dizzy and lightheadedness from this morning when he was doing exercise. Now, we don't do D-dimer too much. If your main diagnosis is pulmonary embolism, you immediately get 3S score in Wells criteria. Okay? So in that case, you have to go for CTPA rather than wasting time with the D-dimer. 60-year-old male, 10 years history of hypertension, feeling dizzy and lightheadedness from this morning when he was doing exercise. The main thing in here is the exercise caused all this dizziness, lightheadedness from this morning. Smoker, alcohol is positive, blood pressure 138/80 sitting, and lying is 120/75. Currently on irbesartan thiazide and aspirin. Symptom lasted for about 2 hours. So the symptom was lightheadedness and dizziness. ECG was given, which showed SVT, heart rate around 150. So 60-year-old having SVT and had a dizziness and lightheadedness when he was doing exercise. What is the cause of SVT in this patient? Dehydration, ischemic heart disease, hypertension, alcoholic cardiomyopathy. Now, the thing is, it could be dehydration sometimes that can cause SVT. I used to say that it's a dehydration causing SVT, but it has been changed also, and I would like you guys to change the answer as well if you have heard our previous any of these classes. So SVT can cause dehydration can precipitate SVT, and obviously it started after exercise. But for a 60-year-old, a smoker, hypertension, I would rather think it as ischemic heart disease until proven otherwise. Okay, it could be any of it. Alcoholic cardiomyopathy, usually 2 to 3 glasses of wine should not cause it. Hypertension, it is well controlled, so it should not cause it. Dehydration would be a good cause in this patient, but given the age of this patient, keep it as ischemic heart disease. Now, if this patient is 20-year-old, choose dehydration. Okay, so age matters a lot. That's very important to remember. If 60-year-old having dizziness, I would always think about ruling out ischemic heart disease. One of the things comes that why there is no chest pain in this patient if it's ischemic heart disease. That's the only thing that comes in the mind. Okay, but a lot of things can happen. Sometimes patient does not get chest pain, but it still can have underlying ischemia. So we should always rule that out first. Next, ECG with bradycardia and a prolonged QT syndrome. Patient came with chest pain for 15 minutes and then relieved by rest. Troponin normal. Pulse regular and normal. Blood pressure normal. What to do next? So if you get a patient with a bradycardia, prolonged QT, chest pain, which was for 15 minutes, any chest pain more than 15 minutes, more than 10 minutes, that's something which you should worry about. And obviously this kind of patient, let's say it's a 50-year-old patient. Okay. In that case, what you would do, repeat troponin, echo, coronary angiogram, or a repeat ECG. The question is next. Yes. Next means repeat ECG. And then after repeating ECG, you have to repeat troponin also. If it's elderly patient, if you get a chest pain more than 10 minutes, even if it is relieved by rest, you have to go for the full thing. Repeat ECG, repeat troponin, okay? And if possible, you have to also go for a stress test, which is exercise tolerance test, okay? If patient is able to exercise, otherwise you go for a stress echo or dobutamine echo. So you have to go in further investigation in this kind of patient. Is this something clear, guys? Is it getting complicated for you? Diagnosis for that patient, we would keep it as an unstable angina. Or you can say ischemic heart disease. And also this patient will need some other investigation in terms of his bradycardia and prolonged QT. Next, a woman on multiple drugs. One of them is digoxin. She presented with central abdominal pain and tenderness. Pulse irregular, very important. Pulse irregular, digoxin. What are you thinking this patient is on? Like having AF, right? So you know that this is an AF patient having central abdominal pain. Let's say it's a 60-year-old woman. Central abdominal pain in a patient with in an elderly patient who is having AF, what is your most important thing to rule out? Anyone? Can you think about something? I told just now, AF patient can have an embolic phenomenon, and the embolism can cause mesenteric ischemia. And a mesenteric ischemia patient get a central abdominal pain like this. Okay. So any elderly patient coming to you with a history of AF, you should, and also having a central abdominal pain, especially coming after eating, 15 to 30 minutes after eating, having parectal bleeding, that's mesenteric ischemia. You have to do a CT angiogram to diagnose it. They're asking that apart from CT, what is the most appropriate next investigation? So apart from CT, we also do serum lactate. Why? Because when someone got ischemia, there will be lack of oxygen. When there is lack of oxygen, there will be anaerobic oxygenation. Now, when there is necrosis and ischemia in that tissue, there will be production of lactic acid. And that's why serum lactate will be really high in this patient. Any ischemia, lactate will go high. So that's why along with the CT scan, we can also check the serum lactate. No need of doing digoxin level, lipase, or abdominal ultrasound. This will not give you anything. When we do the GIT, we will discuss about this in detail. Okay, now hypertension. A 23-year-old man coming for follow-up. His bilateral arm BP 140 to 160 to 110. So this is the range on several occasions. So obviously hypertension. He gets occasional headache, otherwise everything normal. Heart rate okay, with a mild left ventricular hypertrophy. Patient was given beta blocker, thiazide, ACE inhibitor, but still BP is 150 by 100. Now this is called refractory hypertension. Refractory hypertension in a young population like this, what is your most likely diagnosis? Yeah, renal artery stenosis. This is a very common phenomenon. It's a secondary cause, and refractory hypertension like this in a younger population, we always want to rule out renal artery stenosis. So you have to do a duplex ultrasound of the renal arteries for that. Now, other option like echo, repeat ECG, triamterene, ophthalmoscopy, this is not needed at the moment. Okay. Now, first thing you need to do is to diagnose it. So RATS, renal artery stenosis, should be considered as a cause of high blood pressure in people who are, now don't think that it's only people who are older than 50. People who are younger population, they also get RAS. When they develop high blood pressure or a marked increase in blood pressure. This is the other one, cannot be successfully treated with at least 3 or more different type of blood pressure medication. Okay, so when you get someone with a refractory hypertension, you should rule out renal artery stenosis. You should rule out any kidney related problem apart from this, and also any endocrine causes. Okay, so rule out all the secondary causes mainly. Next, an elderly patient taking digoxin and hydrochlorothiazide presents with palpitation. ECG was given. What is the cause of his problem? Now, let's not discuss about this because we have to discuss about the digoxin toxicity ECG. Let me just show you how digoxin toxicity you will find out in the ECG. Okay, we'll discuss about it in the ECG class. In case of digoxin toxicity in ECG, if you look at ST wave, you will get a reverse tick sign of ST depression. See that this is called reverse tick sign. Okay, so all this reverse tick sign in the ECG that suggests digoxin toxicity. Now, this patient is most likely having that. Okay. Not hypo or hyperkalemia. We will discuss about this, so don't bother too much about this one just now. Next, patient on many medication, metoprolol, digoxin, furosemide, ECG given, patient complains nausea, vomiting, abdominal pain, digoxin level is normal. What to do? Now again, same kind of question. Now in here you have got symptom of digoxin toxicity, nausea, vomiting, abdominal pain. This is the most common cause, most common symptom of digoxin toxicity. Okay. Now, even if some can be normal, but patient can have toxicity. Remember I told? And you can look at here. In this ECG, what do you think this patient might have? Anyone who knows ECG really good? Look, just for a clue, look at this lead 2. Look for PR interval. Yeah, very good. Dr. Farhan and Dr. Gloria. So this is a first degree AV block. You can see. So that's called PR interval. This is P, this is R. Normal PR interval is 3 to 5 small square. This is like about 9 to 10 small square. This patient has got a first degree heart block. Okay. Now, again, we will discuss that in the class. Don't get too much over stressed about it because this will be discussed in detail, the blocks and everything. Remember, I told you digoxin can cause almost every type of arrhythmia. So it also can cause ectopic, it can cause AV block, anything. Okay, any kind of arrhythmia can be caused by digoxin toxicity. Now, for this patient, what you will do next? Seize digoxin, seize metoprolol, temporary pacemaker, angiogram, seize metoprolol, commence verapamil. Now, anytime you get that something is causing heart block, you have to stop that medication. Now, this patient having digoxin toxicity, you can see it in the feature, you can see it in the ECG, level doesn't matter. You have to cease digoxin in this patient. Okay. Now, in some cases, if digoxin is not here, sometimes even we might need to cease metoprolol as well, because someone has got heart block, you can't give them beta blocker, calcium channel blocker. Okay. So you have to stop that eventually also. Let's not discuss about WP syndrome today. It's a part of ECG. Now let's have a look in this one. Just similar question, 65-year-old patient present with lightheadedness and palpitation. Examination was normal. He is on perindopril L-troxin. L-troxin is levothyroxine, verapamil, anti-diabetic medication. ECG shows first degree heart block. What is the next appropriate treatment? First degree heart block, you have to look for any medication is there which can cause it. So what you need to do? Increase L-troxin, stop verapamil, stop perindopril, add digoxin. Verapamil is a rate limiting drug, right? So you have to stop this one. So look for any of the beta blocker, calcium channel blocker, or digoxin in heart block patient. Okay, next question. A pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. X-ray shows bibasilar effusion, cardiomegaly. And on exam, you can get a bibasilar Krebs. What is your next appropriate investigation? ECG, echo, D-dimer, CTPA. Guys, next appropriate. Next, yes. Always, guys, ECG. Let's see that even though you knew, still you choose echo. If they ask what is the most appropriate investigation for her, that's echo. If it's next, we have to do a ECG first. It's a very, very commonly asked question. And even though you know, you will choose echo, in many of you, and they know it. We never do echocardiogram before doing an ECG. A patient who had a recent insertion of pacemaker coming to you with a difficulty in breathing, with a faint heart sound. Saturation 96, BP is low. So hypotension, faint heart sound, raised JVP, no ECG given. What is the investigation of choice? Tell me your diagnosis. I've given you a triad: faint heart sound, hypotension, raised JVP. Remember the triad? This patient has got cardiac tamponade, Beck's triad, right? So even if it's not just a tamponade, it's a pericardial effusion at best. So what's your investigation of choice? Chest X-ray, CTPA, ECG, or echocardiogram? Now they're asking investigation of choice. That means the definitive one. So then you choose echocardiogram. If they would ask you what is your next investigation, then you can do a ECG. If patient mainly having any difficulty in breathing, chest pain, then you can do ECG also. Next, another kind of unusual syncope related question. A hypertensive and a diabetic patient, and it's an elderly patient, like let's say 60, male, presenting to you with a history of numbness, nausea, and sweating. He developed dizziness while urinating. Pulse irregular, ECG shows atrial fibrillation. What is your diagnosis? MI, micturition syncope, and vasovagal syncope. The bottom line of this thing is that if you get a patient who is elderly, diabetic, hypertensive, they are high risk population. You don't think anything apart from myocardial infarction if you get nausea, sweating. Okay, silent MI. Yes, Dr. Anna, very good. So you always, now it could be a micturition syncope, vasovagal syncope, it can be, but you have to rule out MI in this patient. There is nothing else that comes first in here. Micturition syncope can happen in older men, especially during the night time, when they actually leave their bed and then stand to pass urine. This happens as a peripheral vasodilation. It can be a cause in this patient, but you have to choose MI in your exam because this patient can have MI also. You don't know it until you do a ECG and a troponin. Next, an old woman brought after fall, now confused, was on warfarin. You can see bruises on both thigh and buttock. Troponin is 0.08. CK is 1000. So CK is increased. What is the diagnosis? Recent MI less than 12 hours, MI in 4 hours, rhabdomyolysis. Very common presentation in Australia. What happens that elderly patient lives alone at home, and then sometimes they can have a episode of confusion, or they can have episode of fall, and they might lost their consciousness and stays on the floor for, let's say, like 12 hours or even 24 hours. And then someone came in the home and patient is not attending to the doorbell and then called an ambulance or a police and found out the, the elderly lady is on the floor. Someone who has a fall and is staying on the floor for a long period of time, their muscle starts to break down. And the myoglobin that is coming out of the muscle breakdown, that starts to cause a lot of problems. Especially you will get red urine because of myoglobinuria that deposit into the kidney, causing kidney failure. Patient is super dehydrated and their CK will be sky high. Okay, that's what is rhabdomyolysis. So you can go through this med bullet to have some idea about it. Patients with rhabdomyolysis are in a lot of risk of renal failure, acute tubular necrosis. They can also get dehydration, hyperkalemia, hypocalcemia. So it's a very, very important thing to get it as early as possible. And this patient, the management first start with IV fluid because you need to hydrate this patient. So see that rhabdomyolysis, muscle tissue breakdown with release of myoglobin into circulation. That causes elevated CK level. You get a dark reddish brown urine due to myoglobinuria. Okay, next, a patient on medication for hypertension, perindopril and indapamide. She feels dizzy when get out of the bed. Happening for a while, she also had some falls. Blood pressure 160 by 100. History of AF. What is the next investigation? Echo, chest X-ray, Holter monitor, 24-hour BP monitor, repeat for postural BP measuring. We already discussed a lot about this. Just think a little bit. This patient feels dizzy when get out of bed. What's your most likely cause? Postural hypotension. You have done a blood pressure. What you have to do actually, before you go for Holter, you should first find out if this patient actually having postural hypotension or not. So you do a repeat postural BP measuring. You haven't done that yet, right? And you don't know that is it a standing or a sitting BP. Whatever it is, you have to do a repeat test first. Okay, at least two blood pressure measurement in a standing and sitting position. If it shows that a patient having postural drop, then you can say this is a postural hypotension. Let's discuss about this one. 57-year-old man complains of anorexia and weakness. Now you guys can see that I'm skipping some of the question. Those questions actually needs more explanation, and throughout the course when you will get those theory done, then we will discuss this. Okay. 57-year-old man complains of anorexia and weakness. Known case of CCF on digoxin 0.25, furosemide hydrochlorothiazide, lab value CBC normal, complete blood count, sodium 131, so it's little low, potassium 3.1, also low, atrial rate 180, ventricular rate 110. So anorexia and weakness in a patient of CCF who is on digoxin, furosemide hydrochlorothiazide and having a low potassium. What do you think that you need to do in this patient? Increase furosemide. If you increase furosemide, you will lower down the potassium more. So can't give it. You want to give hydrochlorothiazide in a patient having hypokalemia? No, because it will cause a lot of worsening of your hypokalemia. How about defibrillation? No need, right? This patient, it's not having any VF or anything. Same with cardioversion. First and foremost in AMC MCQ, always think about it's medication related. Most of the time, if there is a medication list in the exam question, think about medication causing the problem, most of the time. Now, remember digoxin can cause hypokalemia. Not actually not hypokalemia. So sometimes what happens in a patient who has hypokalemia, they can get digoxin toxicity, right? So that was the discussion we had. Now this patient having hypokalemia, and that can cause digoxin toxicity in this patient. Anorexia is mainly coming from digoxin toxicity, hypokalemia causing the weakness. Okay, this patient, you actually have to stop digoxin and give some potassium, and that will cause all the problem gone. Okay, kind of tricky question, right? In exam, if you get this sort of question, it becomes really hard if you don't know those digoxin toxicity things that we discussed in the class. Any question in here? Okay, let's move on to another controversial cardiology question. Aboriginal lady has mitral stenosis and dyspnea. On chest auscultation, bilateral basal crepitation is positive. No fever, cough, sputum. Chest X-ray given with bilateral perihilar opacities like coins. What is the diagnosis? It's one of the controversial questions that you will ever come across. You will be given a chest X-ray, and that will give you a whole lot idea about the cause. So you have to get the chest X-ray. A lot of question comes from the same stem with different diagnosis and different chest X-ray in the exam. So if you look at here, what do you think this patient has got? According to this X-ray test, you can see the cardiac silhouette is obviously enlarged, so cardiomegaly is there. What is this opacity? In sarcoidosis, we should not get cardiomegaly. That's the one thing. Remember the batwing appearance that we talk about? That's what it is. If you get cardiomegaly, batwing appearance, and now patient having dyspnea and bibasilar capitation, you don't think about TB, lymphoma, anything. You think about left ventricular failure immediately. Okay. Now, saying so, question comes with a lot of other things. Like sometimes they give you cough, no basal capitation. Then you might need to think about TB. So depending on the X-ray, depending on the symptom of the patient, the same question can come in different form. But for this particular question, it's most likely left ventricular failure. Now, some of you might think that mitral stenosis can cause pulmonary hypertension, and that's the cause. Now, pulmonary hypertension patient is not symptomatic most of the time. Like they don't have dyspnea. They usually don't cause bilateral basal capitation. And the chest X-ray of pulmonary hypertension looks like this. See that you will not get perihilar opacity like the other chest X-ray. Most of the time you get enlarged pulmonary arteries, sometimes like this, and sometimes you get like this. So that's what you get in a patient with pulmonary hypertension. Okay, so chest X-ray will give you a lot of idea in this question. You have to look for the chest X-ray. You have to look for the symptom of the patient. If patient have low-grade fever, chronic cough, you have to consider TB as well in some question. Okay, now this is our last question for tonight. A lady 75-year-old has hypertension, diabetes, well controlled on drugs. She has an episode of chest pain during walking for 15 minutes, which is relieved after rest. Current medication, ramipril, metformin, metoprolol, blood pressure fine, heart rate 54. Which of the following investigation will you consider next? Serum troponin, thallium scan, Holter, CT angiogram. We already discussed this kind of 75-year having chest pain for 15 minutes. Even if it is relieved after rest, you have to do a troponin. Okay, first do troponin, then you think about something else. All right, guys. So all good. Any questions so far? So that will be the end of the cardiology question solvation. There are also some other questions. If we get some time in our course, we will also discuss the other question. But that's pretty much everything that's needed for now. Okay. So there's a lot you guys have learned, and obviously you might have understood that having a good knowledge on theory and also listening to the lecture. In the lecture, I actually go through the most of the questions that you are actually learning now, because the questions are inside my head. I know what to discuss with you. So in this way, the more you have a theory knowledge, the more easier it becomes to solve questions. Yes, Dr. Karishma, you can always do that. In any tricky recalls, you can always post it in our MCQ group and discuss among each other. When you also get into the course, you will be also joined in our secret group where all the candidates from past, present, they always solve questions with each other. So that will be also important for you. All good. Do you guys have any question? Now, going through the course again, because this is actually your last class with me of the free 2-week session. And the next class will be taken by Dr. Rabia, and she will do some random question solvation with you. And she also takes class every week, once a week. So 3 classes, 2 classes will be done by me. Some of them will be theory class, some of them will be question solvation like that. Okay, and also let me just go through the course content a little bit so that you guys have an idea about the course and you can ask me any question that you want. Okay, I will show you the video that I have shown you in the first class, and then we will go from any of the questions you guys are having about our MCQ course. Just a second. So let's have a look through this video about our course. And if you guys still have any question about it, feel free to just ask me. All right. So thank you everyone for having a look on that. So do you guys have any question about the course? And also one of the thing I wanted you to know that there is another session that's coming up. It's mainly for our AMC clinical candidate, but you guys might feel interested. It's about the AMC pathway, way of registration, and where you are actually looking forward to. We are going to have a discussion on that on this Friday, on 18th, at the same time at 8:30. Okay, so if you want to do that, just I think I will just post that in your group as well in the first aid AMC MCQ. If you think that you are interested to know about it, feel free to join that discussion. But it's mainly for our clinical students who are mainly looking for job and everything. But it's always a good idea to know about where are you heading. That's fine. And about the next topic, Dr. Karishma, I will upload the schedule in your Facebook group. And the next class, Dr. Nahreen, is on 17th with Dr. Rabia. And normally your class is always on Sunday, Tuesday, and Thursday. So you will get the full schedule after this 2-week session is done. So you will get it in your course Facebook group. And for the payment and registration, Dr. Yash, just send us an email or inbox me. Then we'll send you the payment link and invoice. It's already started. I don't know who is using Redmi Note 10 Pro. So whoever you are, we already started the course. This 2 weeks free session that you are joining, that's a part of the course. Okay. So if you want to continue with the next classes, just let us know and just make the payment. Just send us an email that you want to register for the course, and you will be into the course by that time. Okay. You guys still has got a lot of time to get registered and enroll. So just start the process if you're interested. Facebook, do you guys have any question? No question I can see. So that should be fine then. Yes, you will have access to the lectures that you have missed. All of these lectures will be posted in your software as well once you get enrolled. And these are also available in YouTube at the moment. Okay, so if you think that you missed the initial few classes, you can always get it by the recording in the YouTube. And if you just go into our Facebook group and search it in the search option by writing recording, you will get all the recording, because all the recording has been already uploaded in your Facebook group. All right, guys. So it was a very good time with most of you. And I guess that many of you are going to enroll into the course. I can see that. And if you are still interested, just let us know about it and we will start the enrollment process. Thank you all. I wish you all the best.